students, in today's session we'll be discussing some of the multiple choice questions which we gave in the grand test of the INI-CET. We'll be discussing the questions of medicine and related subjects. So this is the first question. There is a statement, assertion and a reasoning that has been given. So at Donnan's equilibrium, the side containing the non-diffusible ion has a higher concentration of osmotically active solutes, and the reason given is the presence of these non-diffusible ions alters the distribution of the diffusible ions to maintain electrochemical equilibrium. So the Donnan's effect, what we call it as the Gibbs-Donnan's effect. Now basically that is the non-diffusible ions. Primarily it is concerned with the proteins which are non-diffusible through the membrane that is there, which remain on one side of the membrane. So that is the statement which is there, which is definitely present. The diffusible ion primarily is the sodium, potassium, etc. So that is what is maintained by this entire Donnan's equilibrium that is there. Now what we have to understand is at the equilibrium, the side containing the non-diffusible ions ends up having highly osmotic active substances, the higher negative membrane potential and more cations and fewer anions. So anions go to the opposite side. That is what we get in equilibrium that is said. So the presence of the non-diffusible ion alters the distribution of the diffusible ions is also right, because the sodium, potassium and the anions and the cations are the ones which are moving. The non-diffusible ones cannot move. So here at Donnan's equilibrium, when we say it is, the statement is correct there and the reasoning is also correct. So both A and R are true, and R is correct explanation of A is the correct answer for that. So the reasoning part is the correct part there. So because of the presence of non-diffusible ions, there is an alteration in the electronegativity or electropositivities. That's why the ions would move each other. So that point is also correct. So B is the A is the explanation for this, and our reasoning is also proper. So that is why the option A is the correct option in this case. Let's go on to the next question that is there. A 30-year-old male presents with persistently elevated LDL cholesterol, and a genetic analysis shows that the GTPase involved in the vesicle secession of the plasma membrane is defective there. A deficiency of this is affecting which most likely process in the lipid abnormality. So lipid abnormality has multiple processes. So is it a receptor-mediated endocytosis? Is it exocytosis? Is it cell-to-cell adhesion, or the plasma membrane integrity that is there? So remember, if you look at these four mechanisms, let's discuss it in a little brief. If you see the receptor-mediated endocytosis, the specific uptake of the LDL, which is clathrin coated vesicles, happen at the plasma membrane. So that is where the clathrin coated LDL particles are taken up by the membrane that is there, and from there it has a complex that is formed, what we call it as an AP2 adapter complex, where there is a complex between the alpha adaptin, the beta adaptin, the gamma to chain, the alpha to chain, etc. And then it binds from there to the LDL receptor, and there is a recruitment that happens, and the dynamin, a GTPase, it pinches the vesicle from the membrane, very important. So it pinches the vesicle from the membrane, and that will fuse to the endosomes, and then it will be internalized through the receptors, and that is where the hypercholesterolemia is primarily acting. So here there is a defect in the GTPase involvement. So is it affecting endocytosis? Is it affecting exocytosis? Is it affecting cell-to-cell adhesion? Is it plasma membrane integrity? Now exocytosis is process where you are removing whatever. So it is coming out of the cell. So clathrin coated particles, once the LDL is inhaled, then the clathrin is removed. So that is exocytosis. So that's definitely not a correct option here. Cell-to-cell adhesion, it occurs between the cathedrins and the integrins, and it is not related to the vesicle at all. So Once the cadherin and integrin are going to happen there, then it is going to affect that. So that is not in the uptake of the LDL that is there. The plasma membrane, obviously the plasma membrane integrity is very important. The plasma membrane integrity is not present, then they can have abnormalities. But it has no problems with the endocytotic mechanism that is there. It is not related to the transport mechanism. Here the GTPase, which is we say, is primarily related to the transport mechanism. So the correct option for this is option A, that is a receptor-mediated endocytosis. That is the process where getting affected in this case that you would see. Let's go on to the next question that is given here. Match the following hormonal phases with their corresponding feedback effect and the physiological consequences. So they have given two columns. Column A is early follicular, mid-cycle estrogen surge, luteal phase, progesterone during luteal phase. The second column they have given is maintains the corpus luteum and suppresses the GnRH, positive feedback leading to LH surge and ovulation, suppression of further ovulation, negative feedback on FSH and LH secretion. Now, what we have to remember is when you have these various phases that you are seeing, you have the early follicular phase, that's the first phase, where you have a less estrogen, very less estrogen that is there. So it is going to take a negative feedback onto the certain negative feedback that will decrease the FSH and LH. So a decreased estrogen is going to take a negative feedback, and that is going to cause in the early follicular phase that is there. Now the mid-cycle estrogen surge, so what happens, there is an estrogen excess. So there is a lot of estrogen that is there, and that is going to take a positive feedback, and that is going to increase the LS, and that is going to result in the ovulation. That is the mid-cycle estrogen surge that is there. In the luteal phase, progesterone is going to come there. So progesterone is going to come there. It maintains the ovulation, and it maintains by suppressing the GnRH. So it suppresses the GnRs and it prevents the new ovulation from happening. And the last luteal phase, progesterone maintains the corpus luteum. So corpus luteum has to be maintained by decreasing the GnRH activity. So these are the four phases that is going to happen. So as we said, the early follicular phase, there is a decrease in estrogen and the decrease in FS and LH. So what we are seeing here is 4 negative feedback for LH and this one. So that is combined with that. So A is going with 4. The mid-cycle estrogen is going to increase the LH and reduce in ovulation. So B is going to 2. The luteal phase estrogen is going to inhibit the GnRH. So it is going to inhibit the GnRH and suppress the further ovulation. So C is going to 3. And if you see, the progesterone during luteal phase is primarily to maintain the corpus luteum. So maintain the corpus luteum. So D is going to go to 1. So D is going to go with 1 there. So the option is 4, 2, 3, 1. So if you see there 4, 2, 3, 1, option B is the correct answer that you are getting it. So option B is the correct answer. So very importantly, let's just overview the various phases that happens. So in the ovulation cycle that you are seeing, you have the various phases. So follicular phase, mid-cycle, luteal and late follicular phase that is there. So the hormone, this is primarily that is present, and what is the effect that is going to happen? So remember, in the follicular phase, estrogen is low there, and there is a negative feedback happening on the anterior pituitary, resulting in suppression of both LH and FSH. So estrogen is low and inhibits the GnRH, inhibits the FSH-LH. Very important. That's the first phase. In the mid-cycle, estrogen is increased, positive feedback on the anterior pituitary, LH surge, and that LH surge is going to result in ovulation. So estrogen surge, GnRH surge, LH surge, ovulation. The luteal phase is to maintain the corpus luteum. So estrogen, negative feedback, anterior pituitary, decreased FSH and LH. But here is the progesterone which is going to come, and the progesterone is going to further suppress the GnRH. So progesterone is inhibitory on the GnRH, and that prevents the the further ovulation to happen. And later the progesterone, again the negative feedback on the anterior pituitary, decreasing FSH-LH, decreasing GnRH, preventing the further ovulation, and it maintains the corpus luteum. And the late follicular phase is where the estrogen rapidly rises, And this is a unique phase where the estrogen rise surge, you produce at hypothalamus and pituitary, both GnRH and LH will increase. Simultaneously, massive LH surge, we are seeing positive feedback, and it occurs for only 2 to 3 days that's happening. So this is the cycle. You have to remain the hormones, you have to remember what is happening, what is positive, what is negative, and what happens in each sequence that happens. A woman using oral contraceptive pill which is combined estrogen and progesterone, regarding the mechanism of actions of these hormones preventing ovulation, which of the following statements is correct? So they have given 4 statements there. So the first statement states that estrogen alone strongly inhibits LH and FSH secretion. Second is progesterone alone suppresses GnRH pulsatility. Third is the inhibin released from the ovary primarily inhibits FSH. And the fourth statement stands that the negative feedback acts at both hypothalamic and pituitary levels, and that is what is going to happen. So the last statement definitely is correct, that much we know. So 4 is correct. The other options we'll look into it. So estrogen, as we said, there is a negative feedback. So LH and FSH, estrogen has a strong effect on that. So in a small amount, estrogen is producing a negative feedback. At a larger amount, it's going to have a positive feedback that is there. So estrogen alone strongly inhibits FSH, LH is correct. Now progesterone decreases the GnRH pulsatility, and that inhibits the LH surge. So LH surge is inhibited by the progesterone. Estrogen causes the LH surge. So primarily it is going to act on the anterior pituitary, and it inhibits the GnRH release, and that is how it is going to release the inhibit the release of LH or LH surge that is going. Now inhibin, what you see is secreted by the granulosa cells. So you have the granulosa cells in the corpus luteum, and the action of inhibin is FSH and decrease the NH grossly, and to certain extent LH also. So this would help in the later phases that is there, and the OCPs will do that. Whenever you have these, they will cause these spot out there. So the third one is also correct. So in total, all the 4 statements are correct in this case, based on the variety of mechanisms that we are discussing. Coming on to the next question here, a researcher is studying the resting membrane potential of the neuron. The membrane is permeable to sodium, potassium and chloride. The following data is available. The sodium ionic site, that is the intracellular fluid, is 15, at the extracellular fluid is 145, potassium is 140 and 5, the chloride is 10 and 110. So the permeability ratios is given as 1:0.04 is to 0.05. Now which of the statements is most accurate regarding the membrane potential of the neuron? Now the membrane potential of the neuron, based on these values that we are seeing. So the resting membrane potential is close to Nernst potential at sodium due to its high extracellular concentration, that is what is given. Goldman's equations must be used as the membrane permeable to multiple ions with various permeabilities. The membrane potential is positive because chloride is moving from outside to inside. Nernst equation is sufficient to determine the membrane potential as sodium dominates the ionic gradient that is there. So here please remember the Goldman equation they have given and the Nernst equation. These are the 2 equations that have been given. The Goldman Hodgkin Katz equation, that is what is the primary equation which is going to check about the resting membrane potentials when you have different ions. So here we have sodium, potassium, chloride, all 3 ions are there. So multiple ions permeability is determined by the Goldman equation. So that's definitely correct. So that point is very, very correct that we are discussing. Now do the other points validate here. So you have the multiple membrane potentials in millivolts that is giving us. It is a log of the intracellular, extracellular sodium into the plasma sodium into the permeability coefficient that you are taking, and this is the formula which is computed by that, and that is how it is going to tell you the value of the membrane potential that you would see here. Now the resting membrane potential is closest to the Nernst potential of sodium due to its extra. So it is while sodium in the extra component, its permeability is very, very low. Sodium permeability is 0.04 compared to potassium. So the impact is very, very minimal. So the A option is wrong there. Now the C option, the membrane potential is positive because chloride is moving from outside to inside. Again remember, chloride moves from outside to the inside, making it more negative. It cannot be positive, so it becomes more negative. It cannot be positive there. And as I said, Nernst equation is sufficient to determine, very important, Nernst equation is only applies to single ion, which is not in this case. Here we have multiple ions. So here we have to apply the Goldman Hodgkin-Katz equation, not the Nernst. Nernst is only for a single ion. Coming on to the next question. A positively charged ion, which has a valency of +1, has an extracellular concentration of 50 and an intracellular concentration of 5. What is the membrane potential in millivolts generated by this ion according to the Nernst equation? Now, as we discussed, the Nernst equation is primarily for a single ion. So, it is 50 and 5. So the formula based on the Nernst equation is primarily the log of the ions, that is whether it is inside versus outside, that is the log we are going to consider, and then we are going to use the valency for that, since if the valency is +1, that is saying. So the formula is log 5 by 50, that is log of 0.1, that is equivalent to -1 that you get it. Now for the EMF that we are looking at here is 61 into the log what we are going to get. So it is -61 millivolts. For a positively challenged ion, this will be +61 millivolts. That's what we are seeing there. So this line flips since it's a positive ion that is there. So the closest option to +61 is +70. So the answer here is +70. So the answer is C for this question that you see there. So the formula, as I told you, is the log of the concentration inside versus the concentration in the extracellular fluid, and the log, and plus or minus 61 is the factor that you would see there. Now what we have to understand about the Nernst potentials we are looking at, a change in the numerator and the denominator in the log only affects the sign, not the magnitude. Very important. It's whether it becomes positive or negative. A positive ion has a higher extracellular concentration, will try to move into the cell. Opposite movement will happen in the intracellular positive ions. So if you look at the total Nernst potential values, this you have to remember. Now the sodium has a Nernst potential value of +60 millivolts. The potassium has a Nernst value of -90 millivolts. The chloride has a potential value of -70 millivolts that is there. Calcium has the highest +130, and magnesium has a +9 millivolts value that is there. So just remember, potassium and chloride are the two minuses, and -90 and -70. Calcium is the highest positive +130, sodium +60, and magnesium +9. Now that is how the single ions valency Nernst equation works there, that you see there. So we would expect these changes to be happening, and that is how you would evaluate it. Coming on to the next question, a physiological experiment of the arterial pressure was anticipated to rise to 175 millimeters per mercury. After activation of the feedback control, the final observer observed that the pressure was 125 rise. Based on this, what is the residual error? Is it 0, +25, -50, or +50? So what was expected is 175. What is got is 125. So what is it? So here the option what you would see there. So option A is corrected, applied, actual rise minus anticipated rise. So actual rise is 125 minus anticipated rise is 175, that is -50. That is what is the one that we are going to there. So residual error is the anticipated rise plus the correction applied. Now residual error is anticipated rise is 175 minus the correction applied. So this is the correction applied, we get it as -30, that is there. So is the 25 millimeters of mercury. Now the correction and the residual error. Now the correction applied is actual rise minus anticipated rise. So actual rise is 125 minus anticipated rise is 175 that is there. So minus 50 we are taking there. So the feedback correction system has caused a correction of 50 millimeters, reducing the pressure. That is what we have understood from that. So if you look at the residual error multiplied there, you look at the factor that we are looking at, actual residual error is only 25 millimeters, not 50, as if you minus directly, it's 50. So actual the residual error which you are saying is plus 25 in this case. So the answer is plus 25 millimeters. In the context of the GPCR signaling, which is the intrinsic enzymatic system of the alpha subunit of the G protein once the second messenger response is triggered. It facilitates GDP to GTP exchange, catalyzes and hydrolyzes GTP to GDP terminating the signal, mediates receptor internalization post-ligand binding, directly binds to extracellular agonist for activation. So please remember this G protein coupled system that is there. When the G protein is alpha subunit is at, it terminates the signal. So how does it terminate? By catalyzing the hydrolysis that is there. So very importantly, we have to understand that the alpha subunit of the G protein contains the intrinsic GTPase activity. Once activated by the efferents, whatever it is there, the GDP is replaced by GTP, and this GTP activates the downside. Adenyl cyclase is getting activated, and that will terminate the other actions that is seen there. Now, there is no activation of GTP exchange, so that is not going to happen there. That only happens that internalization post ligand is also wrong. The directly bind to extracellular thing is incorrect, because the ligand BCR often occurs in the alpha subunit, which is internal. So it is not an extrinsic factor. So the answer for this is B, that you would see there. So if you look at the receptor mediated action, the GPCR has alpha, beta and gamma that is there. So moment you have an ionic influx, this dissociation happens, and that is how the factor is going to be activated. A medical student is analyzing different physiological responses to categorize them into feedback or feed-forward mechanism. Which of the following responses correctly represents feedback regulation, in contrast to those governed by anticipatory feed-forward? So there are two types of feed mechanisms that you're seeing. One is the feedback and one is the feed-forward mechanism. So it is important to know what is which. Now, tachycardia observed in anticipation of a sprint in an athlete during a pre-race warm-up. Reflex increase in heart rate following a sudden drop of arterial blood pressure. Initiation of salivary and gastric secretions upon sensory detection of food. Pancreatic release of insulin triggered by prior to the measurable rise in the blood glucose. Now, which of these is a feedback mechanism regulation rather than a feed forward mechanism? Now, very importantly, what we have to understand is feed forward regulation response occurs before the actual change of anticipation that is happening. So if you have an anticipation, the event has not happened and you are getting it, that is a feed forward. So tachycardia in anticipation, it is a feed forward. Initiation by the sensory detection, food has not gone in, that's a feed forward. Pancreatic release of insulin before the plasma glucose high, it is again a feed forward. Whereas the blood pressure is dropped and reflexly tachycardia happened, it is a feedback mechanism. So remember, feedback mechanism requires the stimulus followed by the response. Okay, that is what we are seeing. There should be a stimulus followed by a response. BP has fallen, that's why the heart rate is increased. That is a feedback mechanism. Whereas all the rest is before the stimulus. So are the feed forwards where there is an anticipation. Remember, anticipation is a word for feed forward. So the answer here is B. Which of the following is true regarding peroxisomes? That's there. So peroxisomes contain enzymes like oxidases, catalases that regulate hydrogen peroxide metabolism. So this is an important factor that you have to remember. This is the primary action of peroxisomes. Proteins are targeted to peroxisomes using signal sequence and peroxins. Peroxisomes arise only from the Golgi apparatus and cannot divide independently. Peroxisomes proliferative activated receptors, that's the PPAR, influence peroxisomes number regulating gene expressions. Definitely, right? So that is one thing that you know. The Zellweger syndrome is a disorder associated with peroxisomes. This is also a very important fact that you have to remember. So one, that is A, D and E are correct. Now left is B and C. So A, D, E are there in only one option. Even before making out only, you can make out that it is there in B. Now according to this, the B is also correct. Proteins are attracted to that and that is going to be producing it. Now peroxisomes are forming from the Golgi apparatus. Now that is wrong. It is formed by the endoplasmic reticulum. And also it has a it can divide independently. It can divide independently. So this is very important for us to understand of peroxisomes. So peroxisomes are very small, around 0.5 micrometer membrane bound organelle. So basically they are going to work against the hydrogen peroxidase. So oxidases and catalases are going to be there. So this is primarily required for us for tackling the oxidative stress. So it has a primary role in the fatty acid metabolism, the lipid metabolism, catabolic reaction, and it's present in the liver, the renal tubular systems. And as we said, it is coming from the endoplasmic reticulum. It can divide itself and formulate again. So PPAR agonists are the ones which we have. Large number of diseases which are going to come from the PPAR, the peroxisome proliferative activated receptors. You have alpha, beta, gamma, etc. of them present, and they are the ones which are nuclear receptors, and when activated they bind to DNA and cause mRNA expression. The Zellweger syndrome is the one where you have absent peroxisomes that you have there. So this is about the peroxisomes that you have to know. 32-year-old treatment of resistant depression, major depression, is offered a novel therapy involving the NMDA receptor antagonist, which is the most likely thing that we are using it. So please remember this, the NMDA receptor antagonist, which is used for the management of resistant depression, is the S-Ketamine. So please remember this, this is used as a nasal spray. S-Ketamine is the one which we use. So it's a non-competitive NMDA receptor which is used for receptor moving, that is there. Now what about the other drugs that we are looking at? So the other drugs which we are seeing, the brexanolone. Now this is a positive allosteric GABA modulator. This is used for the treatment of postpartum depression. It is not for the resistant depression, specifically IV for postpartum depression that we are using there. Next you have the lurasidone. Now lurasidone is an oral antipsychotic. Again, it can be used for depression. It's used. It's an atypical antipsychotic, but it is not working through that pathway of NMDA. The lemobrexant. Now this is a orexin receptor antagonist. It is used for the treatment of insomnia. So the correct answer is S-Ketamine here. Regarding Café-au-lait macules. Now Café-au-lait macules, all of you know, it's present in neurofibromatosis. Now what are the statements? These are the statements that have been given. They are present at birth, are not specific for neurofibromatosis. They have a predilection for the face, trunk, sparing the extremities. Macules of more than 5 millimeters post-pubertal individuals are diagnostic. 2 or more such spots are sufficient for clinical diagnosis of neurofibromatosis. Now remember, Café-au-lait macules are present in McCune-Albright syndrome also. Usually they are not visible at birth. So they are not visible at birth. At later stages of the life, that is where they start appearing very frequently. That is what we have to remember. Now they are not specific because, as we said, it is seen in McCune-Albright syndrome, it's seen in Fanconi's anemia, it can be seen in Legius syndrome. So B is also not correct, that's there. They have predilection for the face and the trunk. Very importantly, face is not normally involved. Usually face is paired. It's the trunk, the backs that is there. Macules more than 5 millimeters post-pubertal is diagnostic, correct. Pre-pubertal it should be more than 15 millimeters pre-pubertal, but post-pubertal it can be 5 millimeters that we see there. 2 or more spots are sufficient. For the diagnosis of NF, you should require 6 or more. 6 or more that is there. So the correct answer for that, for this statement that you're seeing here, the B and C, the option here, they have not given that this is true or false, that is there. So we know that E is correct. Café-au-lait macules are not specific. So B is also correct here. And the portion that is post-pubertal, D is correct here. And 2 or more spots, if you see here. So we know that B and D is correct. So B and D is correct. E. Now E is 2 or more such spots are sufficient for clinical diagnosis. E is not actually correct. We require 6. 2 is simplistic. So if you take the option, C is the most probable option, which is correct in these part that is there, because based on these statements, what is very correct is B and D. B and D is definitely correct. Rest of them are all not correct. But here they have given one more option here, E, which may be considered as true in this context. So option C is the correct option here. 60-year-old male, chronic liver disease, altered sensorium, MRI shows hepatic encephalopathy, blood anemia is elevated. Administration of branch chain amino acids is what is being planned. Which set of amino acids would be most likely to be administered in this patient? Is it valine, leucine, isoleucine, glutamine, asparagine, serine, glycine, alanine, proline, aspartic acid, glutamic acid, and lysine? So for this we have to know the classification of the amino acids. So we know that the amino acids are classified based on whether they are simple amino acids. So the simple amino acids are 2, that is the glycine and the alanine. Those are the simple amino acids. The branch chain amino acids, 3, valine, leucine, isoleucine. So that's the correct option here that you have. The other classification of the amino acids, you should know the hydroxy amino acid that is there, that is serine, threonine. Then you have the sulfur containing amino acids, cysteine, methionine. So all these come under these categories. Then you have the amide containing, very important ones, asparagine and glutamine. These are the amide containing groups that you have. Then you have the dibasic monocarbolic acid, lysine and arginine that comes. All these are the alanine type of this. The aromatic amino acids, the phenylalanine and tyrosine, the heterocyclic tryptophan and histidine. The imino amino acid is proline that is there, and which is derived from proteins. You have the hydroxyproline and hydroxylysine and the gamma carboxylate butyrate. The non-protein amino acids, important, please remember these which are never seen in protein: ornithine, citrulline, homocysteine and thyroxine. The non-alpha amino acid, the last one that you have is the GABA that you would see there. So this is the total classification of amino acids that we have. 55-year-old presents to neurology department, long-standing history of tremors in both hands, which notably improve on alcohol intake. So tremors worsen during the end of the finger nose test. He also exhibits mild head nodding. Which anti-epileptic drug is approved for that? Now please remember, the diagnosis is essential tremor. Alcohol improving tremors is essential tremors. Family history is present. The drug of choice for this is primidone. So please remember, essential tremors, alcohol improves it, beta blockers plus minus. Primidone is a drug of choice, and primidone is it is metabolized into phenobarbital and phenylethyl maleonamide. That's the primary action that is there. We start at 250 milligrams once daily and can go up to 500 milligrams as that as an important part that is there. Phenobarbital, phenytoin and valproate are not used for the tremors. Valproate and phenytoin can also cause tremors, so we don't use that. Drug of choice for essential tremors is alcohol, beta blockers and primidone. 6 months infant, severe respiratory distress, wheezing, cough, nasal flaring. On examination, diffuse crackles are heard. Nasopharyngeal swab confirms that the patient has RSV. So, it is the respiratory syncytial virus, severe infection. Which is the drug and what is the route? Ribavirin inhalation, oseltamivir oral, amantadine IV, acyclovir topical. The drug of choice, please remember, is inhaled ribavirin. Now, ribavirin blocks the RNA polymerase. So, RNA polymerase is blocked by that. So, it is given in various routes. It can be used for intravenous route, especially for severe influenza. It can be used for hepatitis C also. It can be used in that. But in case of respiratory syncytial virus, we give inhaled routes that are there. So, inhaled routes that we are using. So, in infants and children, 200 milligrams you are giving 4 times daily. That's the dose that is there through inhalation that you have. Now, important point about the ribavirin is ribavirin can be used for other conditions like HCV, which I have told you. It's also used for some other viral infections that you'd see there. Now, RSV prophylaxis, you have 2 drugs which have come up for prevention or the RSV prophylaxis. 2 important drugs or the monoclonal antibodies which has come up. One is the nirsevimab and the palivizumab. Now, these are for the RSV prophylaxis. Now, oseltamivir is used for influenza but not RSV. Amantadine, we do not use that at all for resistance is high. Acyclovir is for herpes, not for RSV that is there. So, here it's RSV, ribavirin is the drug of choice. 45-year-old comes to the emergency, altered sensorium, abdominal pain, hypotension, BP is 80-50, severely dehydrated. You know it is Addison's disease case, has stopped medication 5 days, immediate fluid has to be there. What is the most appropriate therapy? Please remember Addisonian crisis, steroids are the main and we would want to give them parenteral steroids. So, hydrocortisone is the best, if not dexamethasone, not oral, it is parenteral that we give it. So, hydrocortisone 100 milligrams stat or dexamethasone 8 to 16 milligrams with IV saline with glucose, very important, IV saline plus glucose. So, dextrose normal saline is there and later you would stabilize, rule out what's the cause for acute adrenal insufficiency, is it an infection, etc. that we use. So, it's not an oral hydrocortisone, not fludrocortisone, not deoxycorticosterone, we have to give IV drug hydrocortisone or dexamethasone. 7-year-old rickets, calcium is 7.4, phosphorus is 2.5, vitamin D is 5. He started on high dose vitamin D. After 2 months, patient comes with vomiting, polyuria, fatigue. You find that the calcium is gone very high and phosphorus is also high and there is nephrocalcinosis. Now, what is this happening? What is it due to? Inadequate dietary calcium, increased vitamin D binding protein, vitamin D toxicity due to overdose, malabsorption of vitamin D due to steatoria. So, definitely it is not decrease of calcium, not malabsorption of vitamin D, because this is vitamin D toxicity. So, that is the answer for this. Now, hypervitaminosis, when we give more than 5000 international unit per day, especially in children, they can come with hypercalcemia symptoms, headache, vomiting, fatigue, diarrhea and stones. So, the main therapy here is to stop the vitamin D and decrease the calcium that would be required for this patient. 26-year-old male weighing 60 kgs comes with fever, chills. Smear is showing falciparum. He has come from northeast India and there is confirmed chloroquine resistance in that area. What is the mainstay therapy? So, as you know, for malaria it is artesunate combination therapy. So, chloroquine is wrong option. So, do you give artesunate with sulfadoxine pyrimethamine plus primaquine, artemether lumefantrine plus primaquine, quinine doxycycline primaquine. So, the mainstay therapy we have as present is the artesunate with sulfadoxine pyrimethamine combination. Artesunate we give it for 3 days, sulfadoxine pyrimethamine single dose, you are giving it on day 1 and primaquine, since it is a falciparum malaria, you are going to give a single dose only that is there. Now, artemether-lumefantrine given daily for 3 days can also be used as this one. That can be a second therapy, what we see there. Quinine doxy can also be used as a second therapy, but the mainstay therapy that we are using here is artesunate with sulfadoxine pyrimethamine that you do it there. 25-year-old under general anesthesia with halothane develops sudden hyperthermia, muscle rigidity and acidosis. Which drug has to be given? So remember, the diagnosis here is malignant hyperthermia, and the drug of choice for that is dantrolene. So remember, malignant hyperthermia is a lethal condition which is produced by the release of calcium from the sacroplasmic reticulum via the RIR1 pathway. So dantrolene is a basic inhibitor of the IR1 pathway, which helps us to decrease this rigidity, decreases this hyperthermia, also protects the cardia. So we give dantrolene 25 to 100 milligrams QID, and that decreases the spasticity. It can be used in other condition also. In dantrolene in a patient with malignant hyperthermia, we give 1 milligram per kg dose. That is what we are going to give. And other drugs which are used, baclofen is a centrally acting monosynaptic, but then it's only for spasticity. Diazepam decreases the GABA activity, but that's not reason here. Succinylcholine is worsening the disease. So our mainstay therapy is dantrolene in this case. 65-year-old hypertensive male is posted for hernia surgery during spinal anesthesia. Shortly after the injection, he develops hypotension, bradycardia. Despite normal respiratory effort, he begins to show reduced coughing ability. Which is the most following explanation for this? Diffusion of anesthesia into the brain. And how do you manage it? By giving atropine. Diaphragmatic paralysis due to high spinal. Dopamine is a drug of choice. Sympathetic blockade causing venous pooling. Drug of choice is methadone. Neurotoxicity of local anesthetic causing treatment epinephrine. So spinal anesthesia very importantly causes sympathetic blockade, and that results in venous pooling. So the drug of choice for that is methadone that we have to use. So the option here is 3. Now respiratory paralysis is rare in a spinal anesthesia patient. So it is very, very difficult that it ascends there. Sometimes a high blockade can cause it, but patients with respiratory paralysis can succumb because of that. Hypotension is very common after spinal anesthesia because of sympathetic blockade causing venous pooling. You can have painful paresthesias, etc. that can happen. Now, diffusion of the anesthesia to the brainstem is very, very rare with spinal anesthesia. Diaphragmatic paralysis, unless you give above C3, it is very rare to happen. And neurotoxicity of local anesthetics. Epinephrine is rare, but it can cause something like a conus cauda. So the main effect that is there is sympathetic blockade resulting in, and the drug of choice would be mephenteramine in that case. 40-year-old severe allergic reaction to cephalosporin is now considered as an alternative antibiotics, which would be the most appropriate choice. Aztreonam, cilastatin, amoxicillin, ampicillin. So cephalosporins are acting. So the cephalosporins and penicillins you cannot use. So you can definitely not use ampicillin, amoxicillin that is there. So the option that is available is aztreonam and cilastatin. Now in case of patients with the penicillin allergy or a cephalosporin allergy, aztreonam is the best drug that can be used. Now aztreonam belongs to a monobactam category. It is an atypical beta-lactam antibiotic. It is a very narrow spectrum, and it can be used in patients who are having that. Cilastatin is not an antibiotic. It is combined with imipenem it's not an antibiotic. It is just to decrease the imipenem's renal excretion. Amoxicillin, ampicillin or penicillin, so cross reactivity of almost 10% is seen whenever a cephalosporin allergy. So we would avoid in them. 62-year-old, stage 3B chronic kidney disease, EGFR is 35, 15-year history of type 2 diabetes, 3-day history of fever, productive cough and green sputum, frontal headache. He is on metformin and glargine. Based on the renal functions, which of these antimicrobial is contraindicated? Now, is it cotrimoxazole, vancomycin, meropenem or tetracycline? So, there is an infection that you see there. Now, whenever the EGFR is low, tetracyclines are contraindicated. Please remember this, tetracyclines are contraindicated. Exception is doxycycline. So, you can use doxycycline. So, drugs which are absolutely contraindicated are aminoglycosides. You should not be using them at all. Vancomycin, cotrimoxazole can be used. Vanco can worsen it. Again, vancomycin is definitely a contraindication that you do, but here we don't use vancomycin, right? Vanco can also be worsened. Amphotericin B is also a dangerous drug. Ethambutol is an important drug. Flucytosine is an important drug which should be avoided. Cotrimoxazole as well as metronidazole, you require to use a little precaution that is there, and that's the main drugs that we should be very careful. Now here it is a respiratory infection, so vancomycin is very less likely to be used. You can use one of these three. Out of these three, tetracycline should be avoided in these patients. Premature neonate after being high dose antimicrobial drug shows signs of feeding intolerance, vomiting and hypothermia, and an ashen gray coloration, which is the drug which is producing it. So ashen bay, so we classically call this the grey baby syndrome, is classically associated with chloramphenicol. Now this is a rare but serious condition that could happen when you are giving a dose of more than 100 milligrams per kg. You can produce this problem where the patient, the kid or the neonate will have feeding intolerance, hypotonia, respiration will be irregular, and it can be causing cardiovascular collapse and death. Tetracyclines will cause a teeth discoloration yellow, Genta is nephrotoxicity, penicillin is generally safe in neonates. Chloramphenicol produces the grey baby syndrome. 45-year-old GERD currently on omeprazole reports that the symptoms are not adequately controlled. Physician considers switching to a different PPI for acid suppression. What can we use? Lansoprazole, patient is already on omeprazole. So lansoprazole, pantoprazole, rabiprazole or iraprazole. Now which of them would be better in these patients? Now of these prazoles that you have, the best one that you could have is the rabiprazole. Now rabiprazole has a faster onset of acid contraction as well as it remains for a longer time. So compared to omeprazole, lansoprazole and ilaprazole, rabiprazole is the best drug that is there. Lansoprazole, pantoprazole remains the same categories. Ilaprazole is not available, but ilaprazole has a longer action but not necessarily fast acting. Rabiprazole is fast and long. That is what we have to remember. So that is your diagnosis in this case. Patient presents with severe muscle weakness, drooping eyelids and difficulty swallowing. The symptoms are temporarily improved by giving cholinesterase inhibitor. What is your diagnosis? Myasthenia, Eaton-Lambert, botulism, Guillain-Barré. This is a characteristic feature of myasthenia. In Eaton-Lambert, it will not improve with anticholinesterase inhibitors. Botulism is a neurotoxin, Guillain-Barré is a neuropathy. So this is a classical fatigable weakness, is a NMJ disease, very, very characteristic of myasthenia gravis that you'd see there. Usually the patient has ptosis, proximal muscle weakness, difficulty in speaking, dysphagia, fatigability. As the day progresses, it will worsen. You can do it identified by doing an EMG, which will show a decremental response. Tensilon or the edrophonium test will be positive. You can use isonipac test that you can do. Acute conditions, you might require to do Plex or IVIG. Otherwise, cholinesterase inhibitors like pyridostigmine is the main therapy. Rule out thymoma, you might require to do thymectomy. Corticosteroids and immunosuppressants are indicated. Now, Lambert-Eaton myasthenia, this is a paraneoplastic myasthenic syndrome. Here, the eyes are usually not involved and it improves with activity, incremental response that you see there, and there is no response to cholinesterase. Botulism is a toxin, flaccid paralysis, pupils are involved, extraocular muscles are not involved. Guillain-Barré syndrome is a demyelinating polyneuropathy, ascending weakness and no fatigability that you see. 26-year-old woman presents with severe menstrual cramps that occur each month and are accompanied by heavy menstrual bleeding. She is diagnosed with dysmenorrhea. Which prostaglandin is likely to contribute to her symptoms? Which drug of class is most effective? So remember, painful menstruation, that is the dysmenorrhea that you are seeing here. So the best drug that is useful for that is the NSAIDs. So it is the prostaglandin F2 alpha and NSAIDs are the best drugs for the pain that is relieving that is there. So the prostaglandin F2 alpha is producing severe uterine contractions and that causes painful bleeding. So NSAIDs are the best drugs that we have to use in these patients. The other drugs which are giving, beta blockers or antiplatelets and leukotrienes, have no major role during the menstrual bleeding. Especially antiplatelets can worsen the bleeding, you should see there, has no major role for the pain relief that you see in these symptoms. Identify the drug to treat this condition. Antifungal, antitubercular, topical steroids, anti-leprosy. So this classical is a lymph node with a lesion, what we call it as lupus vulgaris, which is a cutaneous manifestation of tuberculosis. So you can do the diascopy and you get classical apple jelly nodules that you could see there. So the mainstay therapy is anti-tubercular therapy, not antifungals, not anti-leprotic, not anti-steroids that we use. Skin lesion, this is the phrenoderma, very classical. Phrenoderma or the toad skin. What is it due to? Vitamin A, essential fatty acid, vitamin C, vitamin E. It's vitamin A and essential fatty acid is the correct answer for these patients. Now what about the options that have been given here? So one is combined with all. So possibly it can be seen rarely with vitamin C deficiency and vitamin E, but the correct answer is 1 and 2. So here the answer is D. 25-year-old, epilepsy, currently managed with lamotrigine, complains of generalized rash accompanied with mucosal involvement. So this is a drug side effect. So fever was there, dehydration, 40% of the body surface area is involved, widespread erythema, blistering and areas of skin detachment. So this is a very, very serious condition called as the toxic epidermonecrolysis, when it is involving more than 40% of the body surface area, and this is otherwise called as the Wells syndrome. So toxic epidermonecrolysis, that is the important drug. Systemic features are there, and this is an important point that is there. Now Stevens-Johnson syndrome, when 10% and around is involved, combination is between that, we say it is 10 to 30%, we call it as this. And erythema multiforme is a very localized lesion, So when you have a significant body surface area involved, we call it as toxic epidermonecrolysis. Which of the following test is gold standard for diagnosing H. pylori infection due to the high sensitivity? Is it rapid urease? Is it serology? Is it the carbon 13-14 urea breath test, biopsy and culture? Please remember, among all these, the most highly sensitive, almost 90% sensitivity and 98% specificity is with the carbon breath test. Now that is what the carbon dioxide breath test that is there. Remember, H. pylori is associated with ulcers, malignancies, etc. The rapid urease test has a sensitivity of around 90%. So rapid urease test has a sensitivity of around 90% that you would see there. The gold standard, if you see, with the specificity as well as the sensitivity, is the carbon breath test. The serology is less than 90%, and biopsy is time consuming only for research. So rapid urease test is a high specificity but low sensitivity. Serology cannot distinguish active or old infection, so serology is not much useful. So the main thing therapy that we are using is the carbonic breath test, carbon dioxide breath test. 23-year-old, psychiatry department, recent change in speech and behavior. During the interview, he replies the questions with excessive irrelevant details, but eventually reaches the point. He says things: when I usually go to sleep at 10 p.m. after watching TV, brushing my teeth, saying a prayer, turning off lights, checking in my load locked. Oh yes, I was been sleeping poorly lately. Now what is this speech abnormality called as? Tangentiality, circumstantiality, perseveration or thought blocking. Now this classically describes the circumstantiality, where the patient is going to tell everything, including very small unnecessary trivias, irrelevant detail, but the patient is coming back to the point. So this is a thought disorder Now, tangentiality is where the patient goes totally off and says something totally different. Perseveration would involve repetition of the same words and idea again. And thought blocking is where the patient is abrupt interruption that you would see there. Now, you would get all these things in schizophrenia and psychosis. So, circumstantiality, over inclusion of trivial details. To say that the patient sleeps slow, he says many things there. Tangentiality, out of the topic. Ask about sleep, I sleep on the sofa now, without saying whether the sleep is good or not. Perseveration, repeated the same thing. I need to go home, like that. Thought blocking is sudden halt of flow, where I was going to the store and then silence. So that is the features that you have: circumstantiality, tangentiality, perseveration, and thought blocking. Which of the following features best distinguishes schizoid personality from avoidant personality? Absence of hallucinations and delusions, oddities in speech and behavior, lack of desire for social relationships, presence of history of aggressive verbal disorder that you have. Now, avoidant personality is where they have a social isolation, but there is a desire for connection. So, avoidant, there is a desire for, so desire is present, whereas schizoid, social isolation without desire to have any connection. So, the very specific feature is lack of desire to social relationships that we have. Now, hallucinations and delusions are present in schizoid. Oddities in speech has to be present. Presence of history of aggressive verbal behavior is there. But the difference between avoidant personality still has an intent to become socially responsive or social connections, whereas the schizoid personality does not have that feature. The 35-year-old obese female complains of frequent nighttime awakenings accompanied by episodes of eating. She reports that she consumes 50% of her daily calories after dinner and feels distressed. So, she is complaining of a disorder called as a night eating syndrome. Now, what is the best drug available for this? So, NES, primarily you will have to do a CBT, that is a cognitive behavior therapy, counseling that could be seen, the bright light therapy that could be seen there. But the best drug used for the treatment for that is topiramate. So, topiramate would act on, decrease the nighttime awakening, and also it has an appetite suppressing, in contrast to metazapine, which increases appetite. Lithium has no role, risperidone has no role. Both lithium and risperidone causes weight gain. Metazapine also causes weight gain. Here we require weight loss, so topiramate is the best drug for nocturnal eating episodes. 15-year-old comes with tendon xanthomas. You find his serum cholesterol is 285 and LDL is 200. Lovastatin was given as a first diagnosis. So what is your condition? This is primarily like, so LDL elevated, tendon xanthomas, it is the familial hypercholesterolemia. Very much young patients coming here, and primarily it is because of the defect in the ApoB100 failure that is there, especially the receptors that is seeing there. You could get similar findings in hypothyroidism also, sometimes in nephrotic syndrome and obstructive jaundice also. Tangiers disease is a low HDL disease, not a high LDL disease. Lipoprotein lipase deficiency, which could be familial, we have a high triglycerides, not LDL. Hypermicroglycoproteinemia, both of them will have high TGs. So both of them won't have the tendon xanthomas, which is classically seen in familial hypercholesterolemia as the diagnosis. So if you see the various types of defects that you have in the familial hypercholesterolemia, type 1, type 2, A and B, type 3, 4, 5. So type 1 is the chylomicron fraction, which is elevated. The triacylglycerols is very much elevated. The defect is in the lipoprotein lipase and the ApoC. Here you have the eruptive xanthomas, very characteristic. Type 2, LDL is the fraction, cholesterol is elevated, TAG is normal, LDL receptor, ApoB. Here they have tuberous xanthomas, coronary artery disease. Type 2B, LDL and VLDL. Here you just have the corneal arcus that's there. You do get a cloudy plasma, very important. When you see the bottle of test tube where the blood is drawn itself, you can make out that. In type 3, it is the broad beta VLDL chylomicrons, again presence with xanthomas. Type 4 is the VLDL, you have associated obesity, heart disease. Type 5 is the VLDL and chylomicrons, again associated with ischemic heart disease. A patient has been diagnosed with a non-polyposis colonic cancer and has a positive hereditary defect of polymosis. So, this Lynch syndrome. Now, what is the main defect in Lynch syndrome that you see here? Is it nucleotide excision repair? Is it a mismatch repair? Is it a base excision repair? Is it a point mutation? So, HNPCC, the defects is in the mismatch repair genes. So, the mismatch repair genes deficiency is what we see there. So, the genes are MLH1 and MSH2 genes. So, there is a microsatellite instability that happens, and that is where the problem is primarily with HNPCC that you see there. So, this is the mismatch gene. The nucleotide excision repair, so usually it occurs when there is an UV exposure, and that is where classical disorder is the xeroderma pigmentosa that you would see there. The base excision repair usually not seen with the common diseases. Point mutation can be seen with various exogenous factors, but here HNPCC you generally have a mismatch repair that is seen. 32-year-old undergoing psychodynamic therapy suddenly breaks down while recalling a childhood trauma, expressing intense emotions and crying uncontrollably. After this episode, she reports a sense of emotional relief and greater insight to the current anxiety. So, what is this? Is it catharsis? Is it abreaction? Is it transference? Is it countertransference? This is the classical example for abreaction that you would see there. Now, abreaction is where there is an emotional release. After that, the patient helps better. Now, where you have the other approach like the catharsis. Catharsis is a broader term for emotional release, but abreaction is a part of catharsis where you have a particular memory that comes. Transference is where you project the feeling to some therapist, and countertransference is where the therapist emotional response is coming onto the patient. So, these are all part of the therapy that we use. Which of the following best describes the dependence potential of lysergic acid diethylamide? So, LSD, it's a hallucinogen primarily acting through the 5-HT2A receptor. It's a hallucinogen, agonism of that. LSD is commonly result of severe physical dependence and intense withdrawal symptoms. LSD is associated with prominent withdrawal symptoms but minimal psychological craving. LSD produces psychological tolerance but neither physical dependence nor withdrawal symptoms. LSD has a high abuse potential due to strong reinforcement through the dopaminergic system. Now, very importantly, the dependence profile is basically by the tolerance that affects. So, there is a psychological tolerance without physical. So, the very characteristic feature that you get, the psychological tolerance without the physical defects that you'd see there. So, in LSD, there is no physical dependence, there is no withdrawal symptoms, tolerance happens very rapidly, and that is the reason why you have development of this behavior that develops. The 28-year-old on fluoxetine for depression comes with diarrhea, restlessness, agitation, fluctuating blood pressures. She was recently treated with linezolid for pneumonia. Neurologically, she has hyperreflexia and myoclonus. What is the diagnosis that you have here? So, somebody who is on an antidepressant now has been treated with linezolid, and with that she has diarrhea, lot of cholinergic effects that you are seeing there, and there is fluctuating blood pressure, agitation and myoclonus. So, this is the classical syndrome, what we call it as the serotonin syndrome. Now, serotonin syndrome very importantly happens when you have an SSRI that has been given, and along with that there is a MAO inhibitor which has been put. So, linezolid is a MAO inhibitor. So, there is a sequence. So, that is what is the symptoms that could happen here. So, the supportive care, IV fluids, monitoring this one. You can use cyproheptadine, you can use benzodiazepines, or dantrolene also can be used, but presently treatment is supportive, the drug effect has to go. NMS usually happens with rigid, it is triggered by dopamine antagonist. Hypertensive crisis can happen with MAO inhibitors, especially if they are taking tyramine food, Anticholinergic toxicity would not have diarrhea. They will have constipation, dry skin that you would see. So diarrhea, restlessness, agitation, hyperreflexia, mood swings, myoclonus, seizures, hypothermia, and later the patient will go into cardiovascular collapse. So this is the classical features of serotonin syndrome. Patient with OPD complains of skin problem, and this is what you see. KOH and HP show sclerotic bodies. What is the diagnosis? Is it Cladosporium carolinii, Sporothrix kenki, Madurella mycetoma, Madurella greasy? So the disease what we are seeing here is what we call it as the sclerotic bodies. Our diagnosis is chromoblastomycosis, where you have nodules, ulcerations that it could happen, and the common organisms which produce that is Cladosporium carolinii. Also it can be seen in one more organisms called as the Fonsecaceae pedrosi. This is the most common. Cladosporium is the second common organ. So sclerotic body is classical of chromoblastomycosis. The treatment of choice is itraconazole. We give it with the terbinafine, a combination of itraconazole and terbinafine. You require surgical debridement also. Sporothrix kensis will have lymphocutaneous, no sclerotic bodies. Madurella would generally have your sulfur granules which is going to come. Sexually active males comes with dysuria and mucopurulent urethral discharge. Gram stain says WBCs and there is no gram-negative diplococci. NAT is confirmed for that. What's the first line therapy? Now this is a non-gonococcal urethritis, NGU, so usually caused by chlamydia. So chlamydia is the drug of main therapy that you would see there. Now the drug of choice is 1 dose of azithromycin. So if it is gonococcus, then we will have to give ceftriaxone, but otherwise the main therapy that you have for non-gonococcal for chlamydia is 1 gram azithromycin, 1 tablet stat is enough. Now you can have the serious complications where the patients can have arthritis, urethritis, conjunctivitis, what we call it as the Reiter's syndrome. In females, you can have the Fitzhugh-Curtis syndrome that you have. So you will have to manage it in that way. So your main regimen is the azithromycin. If not, you can give erythromycin, doxy for 7 days, levofloxacin for 7 days. But a single dose of azithromycin is equally effective that you see there. So chlamydia causes urethritis, epididymitis, prostatitis, Reiter's syndrome in males. In females, it produces cervicitis, balanitis, endometritis, PID, and perihepatitis, Fitzhugh-Curtis syndrome. Histological image of a patient who has growth failure and abdominal distension. Patient had anemia, thrombocytopenia, and body pain. Which enzyme is deficient in this case that you are seeing here? So it is sphingomyelinase, beta-glucocerebrosidase, hexosaminidase, or is it G6 phosphatase that you are seeing here? So here the classical appearance what you see a large number of glycogen storage disease that is there, you are finding vacuole. So it is the beta-glucocerebrosidase is the defect pathway that you would see there. And the disease that you are seeing, this is the classical Gaucher's disease. So please remember, this is the characteristic image that you are seeing of Gaucher's disease. Now remember the point here, Gaucher disease, the beta-glucosidase is the deficient fact that you are seeing here. And you have glucocerebroside is the lipid accumulating. You could have adult form, infantile form, or juvenile. Hepatosplenomegaly, anemia, and bone pains is the characteristic feature. By far the most common is Gaucher's. Niemann-Pick, sphingomyelinase deficiency. You have neurological manifestations, organomegaly, cherry red's point of the retina, and usually death within the first 2 years. Krabs is a beta-galactosidase deficiency. Severe mental retardation that's not seen in Gaucher's. Metachromatic leukodystrophy, the deficiency is sulfatidase sulfatase, and here they have neurological defects, optic atrophy, speech defects, and demyelination. Fabry's, alpha galactosidase, progressive renal failure, very important, renal failure, purplish papules, X-linked, and death within 5 years is Fabry's. Adults, you don't see it. So adults, Gaucher's is the most important. Tay-Sachs, hexosaminidase, again the patient will have mental retardation, cherry red spot, death within 3 to 5 years, will not come into adults. Generalized gangliosides, here you have mental retardation, skeletal issues, cherry red spot. Foam cells in marrow can also be seen, similar to Gaucher's, But here in generalized, you will have mental retardation and cherry red spot. That's not there in our patient. Lactosylceral ceramidasis, we have central nervous system problem, and Shandorf's, you have neurological defects. So these are the mucopolysaccharidosis that you have to remember, the defect and the abnormality. Alcoholic patient on anti-TB drugs comes with the tingling, numbness, burning deficiency. What is this? This is pyridoxine deficiency. So the answer is vitamin B6. Isoniazid is the one which inhibits the pyridoxyl kinase, and because of that the PLP formation is defective and causes the B6 deficiency. So thiamine deficiency will produce wernicase corpuscle, it can cause peripheral neuropathy. Riboflavin deficiency produces your angular chelosis, etc. Niacin deficiency produces the pellagra. B6 deficiency is the one which produces neuropathy, depression, can produce macrocytic anemia. B12 deficiency produces macrocytic anemia, produces subacute combined degeneration of the cord. Vitamin C deficiency will produce bleeding gums. Pantothenic acid very characteristically produces the burning feet syndrome. Vitamin A produces the classical neurological manifestations, as well as they can have ocular manifestations, and vitamin K produces bleeding effects that you could see. So this is very important that we have to understand the various deficiencies, what are the clinical manifestations and how do they come in each of them. Thiamine has a wide breadth, so B1, B6 and B12, common deficiency in alcohols can produce neurological complications. So this table is very, very important for us to understand what are the defects and what are the deficiencies that can cause. Also remember, vitamin B12 deficiency will increase the homocysteine and methylmalonic acid, so the patients can have stroke because of that too. Mother returned to find her child struggling with breathing difficulties after coming to contact with the rotenone while bathing with the pet. What is the most common condition that you are seeing here? Is it the succinate dehydrogenase inhibition, NADH ubiquinase oxidoreductase inhibition, cytochrome reductase or cytochrome oxidase? So rotenone is a pesticide, what you are seeing here, rotenone, and that will inhibit the complex 1. Now the complex 1 is the NADH ubiquinone oxidoreductase. So complex 1 inhibition is the result from this, and because of these, this patient is going to have severe cellular hypoxia that you would see there. So remember, the electron transport system has 4 complexes. The first complex is the NADH-Q reductase. The second complex is the succinate, co, that's the second complex that's coming. The cytochrome 3 is the third complex, and the cytochrome oxidase is the 4th complex that you have, and each of them are inhibited by each of them. So if you see the 1 is inhibited by the rotenone that you are seeing there, complex 1 is getting inhibited by that. The complex 3 is inhibited by the cyanide. So cyanide is the one which inhibits the complex 3. Carbon monoxide is the inhibition of the complex 4, carbon monoxide that would come. Even the azide would inhibit the complex 4 that you see. So here it is rotenone, so it's a complex 1, so the answer is B. So please remember the various effects and the site of action of the electron transmitter inhibitor. The rotenone is the complex 1, amatyl is also complex 1, antimycin is complex 3. Then you have the main thing, cyanide, carbon monoxide and azide, all are going to complex 4. The 2,4-dinitrophenyl is uncoupling agent, the pentachlorophenyl is also an uncoupling, and oligomycin is inhibiting the ATP synthase. All of these will act on the electron transport and cause severe respiratory distress. All of features of introns. So you know, in the DNA you have introns and exons. Now the introns are very important to prevent mutations. So please remember, introns are required for preventing mutations. So mutations are prevented by that. So what's the action for that? Introns do not encode for proteins. The spliceosomes is responsible for the removal of introns from the pre-mRNA. Introns can be transcribed but cannot be translated. The presence of introns lead to high chance of mutation. Now that is the wrong answer. The other 3 are correct. So introns are non-coding sequences that are present there. Exons are also there. Now these are important for preventing the mutations that you would see. So this is how the introns and exons are located. The splicing would happen in the pre-mRNA so that it doesn't get transmitted into the protein. Now the child has come to the pediatric OPD with developmental delay and growth retardation. There is megaloblastic anemia which is not responsive to vitamin B12 and folate. Now what is this condition? Now severe megaloblastic anemia with growth retardation is very characteristic of orotic aciduria. That's due to the enzyme OPRTase and the OMP decarboxylase. It's autosomal recessive disorder that you could come which is manifesting like this. Remember, it's a urea cycle enzyme that is getting defected. Leishman is a porphyria metabolism, not to this metabolism. So you can see the urea cycle effects that you see there. So the orotic acid urea may occur due to either the ornithine transcarboxylase deficiency as well as the carboxymalphol formulate accumulates, and that results in this megaloblastic anemia and growth retardation that you would see there. 2.5-year-old comes with hypotonia, floppiness, difficulty in feeding, macroglossia. On examination, you find that the patient has hepatomegaly, weight is 2.8 kgs, length of 4.8 centimeters, and you find a gross cardiomegaly on an X-ray. What is this disease this patient is saying? Is it Pompe's, Epstein's, TGA, or von Gig's? So glycogen storage disease, very characteristic. This is the Pompe's disease that would come. Now it is important for us to understand what are the various types of diseases. So you see the first disease that you have here, that is the von Gig's disease. The type 2 is the Pompe's disease, where you have the lysosomal maltase, and that causes the cardiac part. The type 3 is the Cory's disease, the debranching enzyme deficiency produced with hypoglycemia and hepatomegaly. Type 4 is the Anderson's, where you have hepatosplenomegaly and hypoglycemia. Type 5 is the McArdle's disease, excise intolerance and normoglycemia. Her's disease is type 6, Torrey's disease is type 7, and then you have the other less important ones that you would see. So identify this graph. So here you have a graph that has been given. Is it competitive inhibition? Is it non-competitive inhibition? Is it an uncompetitive inhibition? Is it an allosteric inhibition? Now this is what we call it as the Lineweaver-Burke plot, classically seen pattern that you see in a non-competitive inhibition. The number is written already there. So that's the non-competitive inhibition that you would see there. Non-competitive inhibitors decrease the Vmax of the reaction. That is how you see there. The competitive inhibitors increase the Kmax without having any effect on the Vmax. The uncompetitive inhibitors decrease both Kmax and Vmax, and the allosteric inhibitors do not have any classical pattern that you could see. So this pattern is classically of non-competitive inhibitor. 18-year-old has been brought by the police accused for sexual assault. He claims that he is 16-year-old. Now which is the X-ray that you want to see? Wrist and knee joint, elbow and hip joint, elbow and ankle, shoulder and skull. So very characteristically the wrist joint is what you are seeing there, because the lower end of the radius and the upper end of the tibia fuses at 18 to 19 years. So lower end of the radius, upper end of the tibia. So that's a very important. So fusion of various joints you should remember. The elbow joint is 16 years. The ankle joint, as I said, is 16 to 17 years. The hip joint is 17 to 18 years that you'd see there. The knee, shoulder, wrist is 18 to 19 years. Iliac crest, etc. Would be around 20 to 21 years. The females is 1 year earlier than males. A man experiences sexual arousal while wearing his female partner's dress and heels, but denies any attraction to males. What is this called as? Voyeurism, transvestism, gay sexual preference, or gender dysphoria. This is a classical example of transvestic festicism, otherwise called as the eonism, where they get the sexual arousal when they wear nightgowns or slips or the bras or the lingerie of the females that you would see there. Voyeurism is where the patient has a desire to see somebody undress or naked. that is voyeurism, that is what you said. Gender dysphoria is a strong persistent feeling of the other gender, and he has a discomfort when he is with the identified as his own gender. That is what we call as gender dysphoria. Now, Marshall's triad, that is punctate laceration, bruises and abrasion, is characteristic of which type of injury? Primary blast injury, secondary blast injury, tertiary blast injury, or quaternary. Now, the primary blast injury means the blast injury presents with internal and absence of external injury. That is what you have to remember. Secondary blast injury is due to the flying debris or the shrapnel or the bomb. The tertiary injury is when you caused thrown out by the against a solid object, and quaternary injuries are because of the burns or the toxins or the gas, etc. So, punctate laceration, bruises and abrasions are very, very characteristic of secondary blast injuries. It is not seen in other. Student consumed unknown substance and presented with shock and pulmonary edema. Silver nitrate test was positive. Now, what is the compound which you have silver nitrate positive? It is a toxin here, so it is a very, very characteristic feature of aluminum phosphide poisoning. So, aluminum phosphide poisoning comes with pulmonary edema and a positive silver nitrate test. The treatment of choice especially is MAC-Sulf. So, antidote here is magnesium, and Paralidoxam and atropine is for OP poisoning, BAL is for heavy metals. So, aluminum phosphide will generally produce local irritation. In the severe form, it produces pulmonary edema and respiratory distress and heart failure also. It can produce nephrotoxicity, neurotoxicity and hepatotoxicity also. The drug of choice for aluminum phosphide: give a gastric lavage with potassium permanganate, stabilize the airway, activated charcoal to be given. So, magnesium sulfate can reduce the organ toxicity that can happen because of that. So, if you look at the side effects of the patients who are developing aluminum toxicity, in mild exposure, it's only the mucous, mucous membrane defect, mild respiratory distress, etc. As it becomes moderate, they can have neurological toxicity. In severe, they may have heart failure, pulmonary edema, convulsions also. The sexual assault survivor has to testify in court, and an in-camera trial was conducted. What does an in-camera trial mean? Proceedings held in different location, proceedings recorded on camera, closed court proceedings and open court proceedings. So, remember, in-camera would always mean a closed court where there is nobody else around, only the survivor would be there, the judge and the legal representatives only, as minimum as possible. That is called as an in-camera trial. A newly developed vaccine is tested across several clinical centers involving around 100 participants. The primary objective is to look for the safety and determining the optimal dose. This conducted over 19 months. Which phase of trial? So, safety, it is always phase 2 trial. Phase 2 trial is the safety trial. So, phase 1 where you check for phase safety also, but it's a very small group you are checking at, and it is not for dosing. For the dosing as well as the safety and monitoring the little side effects is the phase 2 time. Phase 3 is for the long term side effects, and phase 4 is the post marketing surveillance. So, phase 2 trial is what we are looking at. 2-year-old unvaccinated child, due to parental refusal, lives in a community where 90% have received 2 doses of MMR. Despite of a local outbreak, the child remains unaffected. Now, why is this happening? What is this reason? Herd immunity does not protect against diseases with animal reservoirs. Measles is not a vaccine preventable disease in unvaccinated persons. Indirect protection declines if vaccine coverage falls below the threshold. Natural infection provides longer immunity than vaccination. Now, the question here is, which of the following best explains the limitation of the protective effect in long term? Natural infection, long term effect, that's definitely there. Herd immunity does not protect against diseases with animal reservoirs. No, it does. Measles is not a vaccine. No, it's a vaccine preventable disease. Indirect protection declines if the vaccine coverage falls. That's the correct option. So, answer C is the option for this. Now what we call it as a herd immunity. Now entire contagious disease, more than 95% is population is vaccinated, so it cannot come. 90% is not so protective that you see there. That is why C is the correct option. 3-month-old progressive swelling in pus discharge in the left axilla after a few weeks after BCG vaccination. On examination, you find a fluctuant non-tender lymph node. The child is afebrile, otherwise is well. What is the diagnosis? Suppurative lymphadenitis, cox-cervical lymphadenitis, BCG osteitis, inadvertent intramuscular injection. Now, this is one of the common side effects called as suppurative lymphadenitis, which can come after BCG vaccination that you could see there. So, if you look at the common side effects, BCG will have local ulceration. Later, it can produce BCG lymphadenitis, osteitis, disseminated sometimes. DPT usually have fever, local redness. Sometimes they can have something called as a hypotonic hyporesponsive episodes, seizures rarely. Oral polio vaccine, no side effects, rarely with paralytic polio. Measles MMR, fever, rash. Thrombocytopenia, anaphylaxis rarely. Hepatitis B, mild fever, sometimes anaphylaxis. Pentavalent, you can get local fever, febrile convulsions. Rotavirus, GI side effects, rarely intussusception. Pneumococcal produces redness fever, sometimes rarely allergic reactions can be seen with that. During a community health survey, individuals undergo a series of tests in a single visit: blood glucose, lipids, chest x-ray, BP, ECG, even though they are asymptomatic. So this is an asymptomatic series of tests that are there. What type of screening is it? Is it opportunistic screening? Is it multiphasic screening? Is it mask? Is it high-risk screening? Now this is an example where you do simultaneously or doing multiple tests in a single encounter in asymptomatic. This is the classical example for a multiphasic screening that you have. Now the opportunistic screening is where a person comes to you for some other reason into your hospital and you're checking doing some tests like a BP checkup in a dental visit. Mass screening is where you screen entire population for a specific disease, one disease. High risk screening is increased only in the people who are high risk, like a pap smear or a mammography in patients with cancer history. That is called as a high risk screening that you have. What pattern of an outbreak spread is typically described with a sudden rise and a sudden fall on a curve? Is it a common source single exposure, mixed exposure, or a propagated epidemic? Now there is a rapid rise and a rapid fall. So that means there is a single exposure and a common source. So the answer is B for this. So remember the distribution of the epidemiological terms that we use when we saw as an epidemic curve that you see here. So here we had a rise and then there is a rapid fall that you're seeing there. So sudden rise, sudden fall, that is a classical example for a common source single exposure epidemic, very classical of a food poisoning that you have. You could have the next pattern, a sudden rise and a gradual fall that is happening. Here it is a common source but to repeated exposure. Example for this classical is cholera, that you would have it. Next you have the third pattern, what we call it as the gradual rise and a gradual fall. Now this is what we call it as a propagated epidemic, which is classical for a viral hep A that you see there. So gradual rise, gradual fall. A diagnostic test X has a sensitivity of 95%, specificity of 90%. It is applied to two different populations. Population A has a high prevalence of the disease, population B has a low prevalence of the disease. Now which of the following is most likely value for a positive predictive value? So please remember, positive predictive value is a person with a positive test is actually having a disease. So positive test, positive disease, that is a positive predictive value. Negative predictive value is negative test, no disease at all. Now it is directly proportional to the prevalence of the disease. Now if the disease is highly prevalent, the positive predictive value increases. Low prevalence, low positive predictive value. So the formula which we use for the positive predictive value is true positives divided by total positive. Now total positive is true plus false positives. So that's the total formula that you would see there. Now what is the true population? So positive predictive value is high in population B. Now remember, population B is a very low prevalence, so it cannot be, so that is wrong. PPV remains unchanged? No. Higher the prevalence, higher the positive value. So that is wrong. PPV is higher in population A. That is definitely right. And PPV depends on sensitivity and specificity. No. PPV does not depend on sensitivity and specificity. It depends on the true positive and false positive. So D is also wrong. So the answer here is C that you see here. Now, which of the following is regarded the fixed rabies virus strain is incorrect? It is used in the preparation of anti-rabies vaccine. It is fixed and predictable incubation period in laboratory animals. It is responsible for the natural transmission. It is obtained by serial passages through intracerebral passages. Now remember, fixed means it is laboratory. It is accepted, laboratory adapted. So that is the very correct answer. It is serially intracerebral passages through laboratory animals, correct. It is used for anti-rabies vaccine is correct. So what is wrong is this is not the one which is producing natural transmission. So here we have a fixed incubation period, 4 to 6 days, and does not spread peripherally. It is only in the brain and it does not produce Negri body also. So the answer for this, which is incorrect, is C. 10-year-old rural area of eastern Uttar Pradesh, high grade fever, altered sensorium, generalized seizures. He was playing outdoor in a paddy field. He is febrile, signs of meningeal irritation, lymphocytic, mild elevated protein, normal glucose. So remember, this is a classical pattern of aseptic meningitis or a viral encephalitis where you have a normal glucose. So it's a viral. So HSV, Japanese encephalitis, enterovirus, streptococcus. Streptococcus is wrong. Now, which of these are the ones? Uttar Pradesh, localized area, paddy field. So there is an exposure. So what do you think this is happening here? Very, very characteristic of Japanese encephalitis that you see there. Now this can be prevented by the Japanese vaccination. You do find a large number of Japanese encephalitis cases who are dying in UP. That is what we see there. Enterovirus, it's used in the rural India, less common, South Asia most common. Herpes simplex will not have such pattern, they will have seizures as a pattern that you would see. Under the National Vector-Borne Disease Control Program, NVBDCP, which of the following vector-borne disease is target for elimination rather than mere control by Government of India? Now, malaria, dengue, lymphatic filariasis or chikungunya. So the answer, please remember, is lymphatic filariasis, which is being to be controlled. The others, so elimination, others are controlled. Malaria is controlled, dengue is controlled, chikungunya is controlled, Japanese encephalitis is elimination, lymphatic filariasis is elimination, Kala Azar is elimination. So elimination is for 3 diseases that are there: lymphatic filariasis, Japanese encephalitis and Kala Azar. Whereas other 2, that is malaria and dengue, is control and chikungunya is surveillance that you see, because it doesn't produce any major disease that you get. Under the revised Kala Azar elimination strategy, which is the first line for uncomplicated visceral leishmaniasis. So please remember, the drug of choice which has been recommended is liposomal amphotericin B, 10 milligrams per kg. It has to be continued for 14 to 21 days, requires for that, and this is available free of cost. Miltefosine is previously the first line, but now there is a lot of resistance. Amphotericin B deoxycholate, yes, but requires renal monitoring, so nephrotoxicity. So liposomal is the one which is better. Pentavalent antimonial is not recommended because you have a resistance of more than 60% for this. According to the National Immunization Schedule, which of the current vaccines is correctly matched? Hepatitis B at 6 weeks, OPV at 6 weeks, MMR at 9 months, rotavirus at birth. Now, which is correctly matched here? Based on the National Immunization Schedule, 12 vaccine preventable diseases are used. So you have the BCG, you have the hepatitis B, you have the measles, mumps, rubella, you have pentavalent vaccines that are available, you have pneumococcal, you have rotavirals, as well as you have the vaccines against hepatitis B that is given. The one which is correctly matched here is the MMR, which is given at C. So if you look at the vaccination schedule, please remember, at birth we give BCG, hepatitis B and the oral polio. These are given at birth. BCG is intradermal, hepatitis B is intramuscular and oral polio is given. BCG is given at the left upper arm, that's a standard, whereas the hepatitis is given with the anterolateral thigh. At 6 weeks, we give the pentavalent 1, OPV, IPV fractional if needed, and rotavirus, and the PCV, pneumococcal, is given at 6 weeks. The 10th week, we give the pentavalent 2, OPV2, rotavirus. At 14th, we give the pentavalent 3, OPV3, IPV, rotavirus, and the pneumococcal second dose. 9 months completed is the measles, mumps, rubella, and Japanese encephalitis in endemic, the PCV booster plus or minus. 16 to 24 months, you give the DPT booster, the OPV booster, the MR, Japanese encephalitis in particular groups. 5 to 6 years, the second dose of booster is given of DPT. 10 to 16, you give the Tdap, adults dose. Pregnancy, you give the TD that is given. These are the schedules which are there. Please remember, a lot of questions asked on this. You have to remember the dosings properly. Which of the following best reflects the policy linkage between nutrition and education under midday meal scheme as per the Indian Public Health Framework? Provision of hot cooked meals for all school going children below poverty line. Improving the nutritional status among all children enrolled in government primary schools. Enhanced child development by integrating health, nutrition and educational intervention. Providing 70 kilocalories and 20 gram protein for every school child between 6 months to 6 age. So remember, it's for school going. So the last option is wrong here. And is it just government schools? No, it's not in government schools. Is it restricted only to cooked meals? No. So the answer which is absolutely correct is C, where you enhance it. So it is not only in government, not only in private, it's everywhere. It's just not because meal program, it does not mean only meal. It can be given in different portions that would be seen there. And providing 70 from is incorrect. It is not from 6 months to 6 age. It is covers children above that is there. So very importantly, school going children is the one which is tackled by this. A population of 50,000, there are 12,000 individuals below 15 years, 30,000 15 to 65, 8,000 65. What is the total dependency ratio? Now, how do you calculate the dependency ratio? So, the population dependency ratio is less than 15 years plus more than 65 years divided by 15 to 65 years. So, if you have 12,000 plus 8,000 divided by 30,000. So 12,000 plus 8,000. So you have 20,000 divided by 30,000. So you know the into 100, that's a percentage. So it comes to around 66.7%. So the answer for this C. So remember the child dependence ratio, the old age dependence ratio and the total dependence ratio totally becomes the dependency ratio that you would see. Match the following based on the causative agent: silicosis, bicinnosis, berylliosis, anthracosis, beryllium, cotton dust, silica. So A goes with 4, that is very characteristically that you are seeing here. Bicinnosis is because of cotton dust, so B goes to 2. Berylliosis is going on to beryllium, so that's 1, and anthracosis is due to coal dust, so that is 4. So that's 3. So the options here is 4, 2, 1, 3. So 4, 2, 1 and 3. So answer is A. So silicosis is basically silica exposure in the sand blasting agencies that you are seeing here, and characterized by apolofibrosis predisposed to tuberculosis. Cotton dust in the cotton was classically the Monday chest syndrome they get. Beryllium is electronic and aerospace, produces chronic granulomatous lung disease. Coal dust produces the black lung disease. Anthracosis or the progressive massive fibrosis can also be seen. So the next MCQ here: which of the following steps in modern sewage treatment is primarily responsible for biological degradation of organic matter? So is it the grid chamber, is it a trickling filter, is it screening or sludge drying bed? Now in the process of the modern sewage, you have either the primary treatment and the secondary treatment. So the primary treatment is otherwise mechanical or physical, whereas the secondary treatment is what we call it as biological treatment. Now what is done in the primary treatment? So in the primary treatment, So you have the screening that happens where you remove large floating objects. Then you do the grit removal. So grit removal is where you remove the sand and gravel out of it, and after that you do the sedimentation, where the settled suspends of the solids that has been removed. So the grit chamber is primarily for the sand and gravel. So that is out here, that is going to be removed from that. Now screening is also for primary, so where a large objects is removed, it is not for the biological degradation that is there. Now coming on to the secondary or biological, here it removes the dissolved or colloidal organic matter, out of which the first process is what we call it as the trickling filter. So trickling filter and the activated sludge, these are the two processes that happen in the biological. The trickling filter, sewage flows over the beds of stones covered with microbial films that digest the organic matter. And the activated sludge is aeration of tanks with microbial which degrades the organic matter. That is the activated sludge drying process. So the degradation of the organic matter is by the activated drying process, whereas the digestion of the organic matter is by the trickling filter. So both of them are for the organic. So here they have asked biological degradation of the organic matter. So it is the degradation they have asked, not the drying. So the actual answer for this is D. So D is the sludge drying bed that is there, where there is a degradation of the sludge or the organic matter, whereas trickling filter is just for digesting the organic matter that you see. The life expectancy of Japanese women is 84.3 years. Since the Japanese have used a highest life expectation, their statistics are used as a standard for measuring the premature deaths. So what is this metric called as? Is it called as Hale, Qualley, DFLE or DALY? Now DALY stands for disability adjusted life years. So that is the overall years that you are seeing. So you have the YLL, that is the years lost to life, YLD, years lost to disability. So combining these two becomes the disability associated life matrix that is there. So the DALY is the one which is primarily used based on the Japanese life expectancy that we use. So DALY, that is the years of life lost and years of life disability together form that. So that's the answer for this. Hale basically is the health adjusted life expectancy. Now that is basically got by the total life expectancy minus the lives lived without health issue. Quali is the quantity and quality of life that we are seeing. The DFLE is the disability free life expectancy. So DALY is the one which is used for comparing the premature death that you see. A 35-year-old male, 2 months history of malaise and fatigue, HbS-Ag is positive and anti-HPC IgM is positive. What is the common diagnosis there? So IgM anti is a classical feature of an acute hepatitis B. So the answer is acute hepatitis B that you are seeing here. Chronic hepatitis B, IgG will be present. IgG anti-HBC will be present, and sometimes you may have the HBs antigen persisting for more than 6 months. That is called as a chronic hepatitis B. So chronic hepatitis B, HbS-Ag is persistent for 6 months. The IgG anti-HBC will be present, not the anti-HBM. Chronic hepatitis C, only HCV antibodies will be present. Acute hepatitis, the HCV RNA levels will be present. So we require to know these markers that you see there. In an acute hepatitis, so acute is in the few phase, more than 6 months is chronic hepatitis. So remember the HBs antigen will come, and if a patient clears it, anti-HBs is coming. IgM is present in the first acute, and IgG anti-HBC will be present for chronicity that you see. 22-year-old pregnant woman visited a sub-center with concerns of eating of papaya that may have caused an abortion. After proper examination, her pregnancy was confirmed to be safe. Now, which health worker should be assigned to follow up her in rural area? ASHA, TBA, Anganwadi worker or the medical officer? Now it's very important for us to understand that this patient should be under the maternal and child care, and this patient has to be followed up by the Anganwadi worker. Now the ASHA, particularly the accredited social health advisor, is a frontline community health worker who visits homes, pregnancy follow-ups, etc. for minor illness. The subcenter setup, which is seen, the auxiliary medical officer, the medical officer will be there. They'll be primarily intended for the medical diseases that are there. And trained birth attendant is for the delivery that could happen. So the Anganwadi worker is the primary worker who have to see that. 25-year-old comes to OPD with vaginal discharge and cervical erosion. Based on the syndromic management of STIs, which code is given? Green, grey, blue and red. So this is classically the green coding that you have to remember. So please remember the codings. So the grey is basically the urethral, anorectal and discharge. The green is vaginal discharge. White is genital ulcerative disease. Blue is genital ulcerative disease, non-herpetic. Red is genital herpetic disease, which is herpetics. Yellow is lower abdominal pain and black is inguinal bubo. Based on this, you treat the thing. If it is grey, it is azithromycin, cefixime. Green, it is vaginal discharge, so secnidazole and fluconazole. White, it is genital ulcerative disease, non-herpetic, azithromycin, benzathine, penicillin that you're thinking. Syphilis is the primary there. Blue, azithromycin, doxycycline, this is a non-gonococcal. Red, it's the acyclovir for herpes. Lower abdominal pain, it is the salpingitis, oophorytis, cefixime, metronidazole, doxycycline, and bubo, azithromycin and doxycycline. So this is the 7 categories that you have under the STI program color coding. 10-year-old, fever, rash, Koplik spots. The diagnosis is clear. It is measles. So Koplik spots are located in the buccal mucosa, bluish white spots, and usually appear 1 to 2 days after the onset of the disease that you see. After that, the generalized rash would come. A poor farmer, history of crop failure, presents with progressive spastic paralysis, upper motor signs and gait instability. What is the toxin? So this is the classical appearance of a pure motor spastic paraplegia, very characteristic of letharism. Now this is caused by the BOAA, that is the beta N oxalyl aminoalanine, that produces this thing. Usually malnourished individuals depend on letharesis due to the crop failure, and that produces that you see there. The other BOAA, that is the aflatoxin. The strychnine produces neurotoxicity, spasticity, and ergot will produce vasospasm and gangrene. So the answer here classically is the BOAA, that is the answer. What is the common differentiating factor between a common exposure, single exposure and multiple exposure epidemic? Is it pathogenic virulence? Is it killing power of the disease? Is the relation with the incubation period? None of the above. So it's very important, what we have to understand is relation with the incubation period, which helps us to distinguish between the single exposure or a multiple exposure. Now single exposure means a common source is there. So you have one incubation period, there is rapid rise and then there is a rapid fall that happens. Whereas you have a condition where you have multiple exposures, you have a rapid rise and then there is a slow fall because there is a continuous exposure that you're seeing, either an STD or a waterborne cholera or a Legionnaires' disease that is there. So what differentiates this is the relation to the incubation period. Single exposure, there is one incubation period only, whereas in multiple, the case spans more than one incubation period. So if there are multiple cholera cases that is going to happen, this is possibly a multiple exposure. If it is one group of them, incubation period is only one equivalent to one incubation period, it's a single exposure that has occurred in these cases. Which of the following best describes the action of aldosterone on renal tubular function? It increases water reabsorption by inserting aquaporin channels in the collecting tubules, enhances sodium reabsorption and potassium secretion in the distal nephron, promotes natriuresis and diuresis through CGMP mediated pathways, inhibits sodium potassium ATPase at the proximal tubule. Remember, aldosterone is a mineralocorticoid hormone which is secreted by the zona glomerulosa of the adrenal, and it is responsible for sodium potassium balance by acting at the principal cells at the distal convoluted tubule. So its main action is because of that. Also, it improves the ENaC, that is the epithelial sodium channels, so that the sodium potassium ATPase activate happens. But all the action is going to happen at the DCT. So the answer correct here is the B, that is where it is primarily acting. That's what you have to remember. So if you look at the aldosterone, it's primarily acting by DCT collecting tubule, ADH collecting duct, ANP is acting at the collecting duct and the glomerulosa. Aldosterone increases the sodium reabsorption, potassium and H plus is excreted. Collecting ducts, the ADH is water absorption through the aquaporins. Aquaporin is primarily ADH action and it is water reabsorption. ANP is going to decrease the sodium reabsorption, increase the GFR and increase natriuresis. That is the atrial natriuretic peptide which is going to act, promotes natriuresis, opposite of aldosterone that is going to be working. 40-year-old woman with long-standing history of asthma and allergic rhinitis comes with fever, weight loss and mononeuritis multiplexer. She has found palpable purpura and there is eosinophilia, elevated IgE, P-ANCA positive, chest X-ray shows pulmonary infiltrates. So this is the classical appearance of Churg-Strauss syndrome, or otherwise called as eosinophilic granulomatosis with polyangiitis. That's the new name. It's a small vessel vasculitis, ANCA associated vasculitis. So what do you find in these patients? So this is the classical appearance of what? An eosinophilia, then the vasculitis, mononeuritis, lung shadows, kidney pathology. Now what this Churg-Strauss does to the kidney? Does it produce eosinophilic interstitial nephritis with granulomas, crescentic glomerulitis with the eosinophilic granulomas, focal segmental necrotizing granulomatosis without eosinophils or granulomas, mesangial hyperproliferative with immune complex deposition. Very, very important. Though this produces eosinophilia everywhere, the granulomas in the kidney are without eosinophils. So it produces focal segmental glomerulonephritis without eosinophils or granulomas. So that is what you have to remember. So if you look at the various vasculitis, be it Churg-Strauss, be it Wegener's, be it microscopic, remember Churg-Strauss produces segmental necrotizing, no eosinophils, whereas granulomatous, that is Wegener's, produces crescentic with granulomas and microscopic produces pauciimmune that you see there. So Churg-Strauss, asthma, eosinophilia, P-ANCA positivity, lung infiltrates are migratory. The Wegener's, no asthma, no eosinophilia, C-ANCA, that is PR3 positive and fixed granulomas, cavities. Microscopic granulomatous, asthma and eosinophilia are rare. Again it is P-ANCA positive and you find diffuse changes in the lung that you see there. A 2-year-old, fever 5 days, bilateral non-purulent conjunctivitis, erythematid cracked lips, strawberry trunk, polymorphic rash, cervical lymphadenopathy, erythema of the hands and soles. What's the most critical complication? Now, all these characteristics is of what we call it as the Kawasaki's disease. This is one vasculitis which is seen in young children, you see it, and the lethal complication is coronary artery aneurysms. These patients can die due to coronary artery aneurysms, and this is the only vasculitis where we do not give steroids. This is the classical strawberry trunk, lymphadenopathy, fever, cracked rash on the body, and coronary aneurysms, Kawasaki's disease. Identify the incorrect statement about Moro's reflex. Absence Moro reflex is seen in grade 3 hypoxic ischemic encephalopathy. Asymmetric Moro's reflex in Erb's palsy. Sudden extension leading to arm abduction and extension appears completely by 28 weeks of intrauterine life. Now, what you have to remember is the Moro reflex begins around 28 weeks of intrauterine life, but it is not fully developed up to 34 weeks. That is very important. So this requires 34 weeks that is there. So that is the classical Moro's reflex. So a complete Moro's is a symmetrical abduction, extension of the upper limbs, opening of the hands and flexion and abduction, along with extension of the head and neck. That is what we see there when the baby is crying. That's the Moro's reflex. So absence of Moro's reflex would indicate a severe form of cerebral damage. Please remember, in a severe form, grade 3 it is seen, whereas it is grade 1, it is not so clearly seen. Asymmetric Moro's reflex, either a clavicular fracture or Erb's palsy or shoulder dislocation or congenital hemiplegia. That is asymmetrical that you see there. 4-year-old child comes to the pediatric clinics with the complaints of fever and diarrhea. The parents report the diarrhea started as watery stool and now there is stools with mucus and blood. What is the organism? Is it Giardia, Rotavirus, Shigella, Salmonella? Remember, Giardia and Rotavirus is only diarrhea, there is no dysentery. Salmonella and Shigella have dysentery, the most common being Shigella. So the answer is Shigella dysentery is the characteristic feature of bloody diarrhea. You can get it in Salmonella, you can get it in E. coli, especially the invasive E. coli or hemorrhagic E. coli, sometimes due to Clostridium difficile also. A 6-week-old male presents with poor feeding, tachypnea and weak femoral pulses. On examination, there is a 20 mm gradient between the upper limb and lower limb blood pressure. Chest X-ray shows this finding. Now, what's your diagnosis? So, if you carefully look at the chest X-ray, you get this, you can see this figure of 3 appearance here. That's the classical of coarctation of aorta. And if you carefully look, you find that there is a rib notching, the inferior rib notching, classical. So this is a characteristic finding that you get in case of coarctation of aorta. That is what you get. So the answer is B. 70-year-old hypertension diabetes comes with the palpitation and dizziness. She has no history of previous strokes. ECG shows this finding. You're classically seeing irregular RR intervals and fibrillary waves. We know the diagnosis is atrial fibrillation. Now her BP is fine, they are saying. So the first step is to control the rate by beta blockers, followed by anticoagulation. If the patient has hemodynamically unstable, only then we would give electrical cardioversion. So the answer is B in this case. 65-year-old, sudden substernal crushing pain radiating to left arm, 1 hour with increased sweating. He is obese, BMI is 22. ECG is showing this finding. What is the most common vessel that is involved? So here you are finding ST elevation in lead 2, 3 and AVF. So it's an inferior wall MI. The inferior wall MI can be due to right coronary artery or left circumflex artery. So how do you say there? If the ST elevation is more, lead 2 more than lead 3, suggest a left circumflex artery. So lead 2 more than 3 is left circumflex. If it is lead 3 more than 2, it is right coronary artery. So if you see here, the ST elevation in lead 3 is more than 2. So the answer is right coronary artery that you see there. Also, the other feature is reciprocal ST depression in AVL. If it is present, it is always suggestive of right coronary artery. 72-year-old, progressive memory loss, getting lost in familial places, difficulty in managing finances, 3 years duration. MMSE is 18/30. Hippocampal atrophy is seen. What is the diagnosis? Vascular, Lewy body, frontotemporal Alzheimer's. This is the classical features of Alzheimer's dementia. Progressive defects, hippocampal atrophy. Vascular dementia will have a stepwise appearance, strokes in the past, and frontotemporal dementia will have classical disinhibitions, language defects, and frontal atrophy you classically see. Hippocampal is not involved. Lewy body will have classical visual hallucinations that you would see. So the answer here is Alzheimer's disease. A 58-year-old man collapses at a mall, found unresponsive, no breathing, pulseless. EMS sees ventricular fibrillation and administers 150 joules biphasic shock, continuous CPR for 2 minutes. What is the next thing that has to be done? Check for pulse after defibrillation, administer another defibrillatory shock if pulse is not found, continue CPR for 2 minutes before reassessing rhythm, administer IV atropine. Now remember, cardiac arrest, whenever you have a VF or a VT, first we do a cardioversion, continue the CPR, monitor for 2 minutes before reassessing the rhythm. So just by giving one CPR or cardioversion does not revert, we have to continue the CPR. So the answer correct is continue the CPR. So whenever you do a CPR, you find VF, give the shock, observe for 2 minutes. Only then you check the rhythm. If the rhythm is shockable, then you do the same thing. So 2 minutes of CPR is mandatory, not that we continuously do defibrillation. You would require to monitor them. So again, remember, the sudden cardiac death could be due to cardiomyopathy, could be due to ischemia, could be due to a massive MI. In young patient, it could be due to Brugada syndrome, WPW syndrome, or ARVD. Now here we have two statements. One is the assertion and the reason. Rh negative woman should never receive Rh positive blood if she becomes pregnant. Exposure to Rh positive RBCs can cause the placenta forming anti-Rh antibodies which can cross the placenta, resulting in hemolytic disease of the newborn. Now, it is very important, Rh negative women should not receive the Rh positive antibodies, because the antibodies would develop and that would result in hemolytic disease of newborn, severe anemia, hyperbilirubinemia, etc. So, both this A and R are, the assertion is positive, the reason is also positive, and R correctly expresses the reason for A. 67-year-old, progressive exertional dyspnea, orthostatic hypotension, recurrent diarrhea. ECG shows a low voltage complex, but the LVH is there on echo. Of abdominal fat burden shows amyloid deposition. Which of the following is most likely differentiating this amyloidosis from ATTR amyloidosis? Now remember, AL amyloidosis versus ATTR, what is the difference? Now AL amyloidosis is associated with monoclonal, usually plasma cell dyscrasias like multiple myeloma. Serum free light chains will be elevated and bone marrow will show clonal proliferation specific for AL that you see there. So the serum free light chains assay and the bone marrow biopsy is a very specific feature which can tell you the specific type of AL. The cardiac MRI will not show the difference, urine analysis will show nephrotic ingrowth, and hepatosplenomegaly will not differentiate. The specific one to differentiate AL versus ATTR is the free light chain assay. 55-year-old undergoing chemotherapy for leukemia presents with fever, hypotension and altered mental status. Blood culture is negative, but the beta-2-glucan levels are high. No focal signs, neutrophils are very low. So there is a sepsis, there is a severe febrile neutropenia and a beta-2-glucan. Now beta-2-glucan is very specific for fungal infection, especially the Candida and the Aspergillus. So Candida, you have to start immediate treatment for these patients. So Candida species is the diagnosis that you see here. Now match the type of envenomation with the likely features. You have the blue-linked octopus, Russell viper, hump-nosed viper, Indian scorpion. The clinical features are neuroexcitation, cardiotoxicities, procoagulant coagulopathy and renal failure, progressive flaccid paralysis, coagulopathy and local necrosis. Now, what you have to remember is the Russell viper. So, Russell viper will produce the coagulopathy and local necrosis. So, B is corresponding to 4. That is important. Now, the hump-nosed viper classically produces renal failure and procoagulant. So, renal failure is the hump-nosed viper. So, C is coagulating with 2. That is what you have to do. So, look for the option where B is 4 and C is. The scorpion, very importantly, it produces neurointoxication and cardiotoxicity. So, D is corrupted with 1. So, left here is A, which has to go with the 3. The A is blue-ringed octopus, which has to go with progressive flaccid paralysis. So, look for the combination. So, octopus is paralysis, Russell viper is coagulant, and this one, both vipers will have coagulant, and the Indian scorpion is neurotoxicity. So, the option which gives this is the D that you see there. So, if you look at the various toxicities, the blue-ringed octopus produces neurotoxicity, autonomic storm, cardiotoxicity and pulmonary edema. The Russell viper, procoagulant coagulopathy, renal failure and shock. The crates usually produces the flaccid paralysis and myositis. Cobra again produces flaccid paralysis. King cobra, flaccid paralysis. Saw-scaled viper, local reaction, procoagulant necropathy. Hump-nosed viper, classically procoagulant coagulopathy. Green pit viper, again procoagulant vipropathy. So remember, the Viperidae generally produces the renal failure and coagulopathy, whereas the neurotoxics, that is the cobra, will produce the flaccid paralysis that you would see. 35-year-old bilateral adrenalectomy following Cushing's comes with progressive hyperpigmentation and headaches. MRI shows the pituitary mass. What is the diagnosis? This is the classical Nelson syndrome. So Nelson syndrome is where for Cushing's disease, where you do, instead of removing the pituitary tumor, you remove the adrenal tumor, it produces rapid hyperpigmentation because of a pituitary tumor that is there. So that is the Nelson syndrome. Which genetic mutation is most commonly associated with X-linked nephrogenic diabetes insipidus? Is it the aquaferrin 2? Is it the AVP receptor 2 gene, ACE gene or CFTR gene? Please remember the X-linked one is associated with the AVPR2 gene mutation, which is the V2 receptor gene. That is the one which produces nephrogenic X-linked diabetes insipidus. So please remember the causes of diabetes insipidus. You could have central diabetes insipidus or nephrogenic. Central, idiopathic neoplastic pituitary probes, familial, Didmode syndrome, Wolfram syndrome, etc. The nephrogenic could be hereditary or acquired due to chronic pyelonephritis, hypokalemia, hyperkalemia, sickle cell disease, amyloidosis, Sjogren's syndrome. What is the characteristic pathognomonic finding in Whipple's disease? Cryptapsis, PAS-positive macrophages in duodenal biopsies, elevated anti-TG antibodies, positive MANTO test. Remember, Whipple's is caused by the organism which is P-positive PAS, that is the Tryptopherema whipplei, which is a PAS-positive organism. Cryptapsis is classically in Crohn's disease, not in Whipple's. Anti-TG is in case of celiac disease. Positive MANTOS is in TB, whereas PAS-positive is characteristic of Whipple's disease that you see. A paracentesis from an ascitic patient shows a SAG of 1.3. So SAG more 1.1 is classically of portal hypertension. So the diagnosis is cirrhosis. Hepatic malignancies, tuberculosis and nephrotic syndrome all will produce the SAG less than 1.1. So the SAG more than 1.1, portal hypertension, portal venous thrombosis, alcoholic hepatitis, Budd-Chiari syndrome, constrictive pericarditis. SAG less than 1.1, peritoneal tuberculosis, carcinoma, pancreatitis, nephrotic syndrome, biliary ascites, perforation. Patient with cirrhosis, bilirubin is 3, albumin is 2.9, PT is 6 seconds, ascites is moderate, encephalopathy is grade 2. What is this Child-Pugh scoring? Now Child-Pugh scoring is going to give a scoring for each of them. Now the bilirubin is 3, so the score becomes 2 for that. When the bilirubin is more than 3, we give a score of 2. Low albumin again gets a score of 2 that is there. Prolonged PT gets a score of 3. Moderate ascites gets a score of 2. Grade 2 encephalopathy gets a score of 2. So the total score here is 11. So poor prognosis, CPT stage 3 it goes into. So it's a prognostic scoring that we use there. We say class A when it is 5 to 6, 7 to 9 is class B, and more than 9 is considered as class C. So Child-Pugh C, this patient, very poor prognosis, requires hepatic transplantation that is needed. So this is the grading system that we are using here. The markers, encephalopathy, mild gets 2, moderate gets 3, ascites none, mild, moderate. Prolonged prothrombin time 4 to 6 is grade of 3, more than 6 is grade of 3. Albumin more than 3.5 is 1, 2.8 to 3.5 is 2, less than 2.8 is 3, here it was 2.9, so it comes to 2. Bilirubin less than 2, 2 to 3, more than 3 that is coming. So based on that we are grading it and we are scoring the patient based on this. 50-year-old male, chronic cough, fever, night sweats, unintentional weight loss. He is a known smoker, close contact, had tuberculosis, chest x-ray shows upper lobe infiltrates, no cavitation, sputum smear is positive, normal WBCs, sputum smear is negative for AFB, normal WBC count. What's the likely diagnosis here? Now all the symptoms are suggestive of tuberculosis. Is it primary tuberculosis, reactivation? Is it non-tuberculous? Is it pulmonary aspergillosis? This patient is having a reactivation of tuberculosis because this patient has a cavity there, upper lobe infiltrates, but there is no cavity and the smear is negative. So we would consider it as a reactivation of tuberculosis. 68-year-old, long history of smoking with the progressive exertional cough, sputum production. FEV1 by FVC ratio is less than 0.6. FEV1 is 40% predicted. Chest X-ray shows hyperinflation, flattened. PO2 is low, PCO2 is high. Now this patient has a severe COPD because FE1, FE2 is less, emphysema is there. What's the most appropriate treatment for this patient that is needed? Inhaled corticosteroids should have been there already, pulmonary rehabilitation, inhaled oral corticosteroids or long-term open. Now among all these patients, when the patient has a hypoxia with the mild hypercarbia, these patients not only requires inhaled corticosteroids, LAMA, LABA combination, pulmonary rehabilitation, but these patients also requires LTOT. LTOT is the one which will retard the progression of the disease. So long-term oxygen therapy domiciliary is mandatory in these patients. 45-year-old stonemason worker, progressive dyspnea, dry cough, bibasal and inspiratory crackles. Chest X-ray is shown here. PFT is showing a DLCO which is restricted with the restrictive pattern. What is the diagnosis? So is it tuberculosis, is it sarcoidosis, silicosis or IPF? So here you find that there are shadows, pleural plaques, lymph nodes with the calcifications. So these are all characteristic features of chronic silicosis that you would see. So this patient has silicosis as a manifestation. 65-year-old, 40 years smoking, fatigue, weight loss, hoarseness, hilar mass, mediastinal lymphadenopathy, biopsy showing these features. Which paraneoplastic manifestation is more specific for small cell carcinoma? Is it hypercalcemia, Lambert-Eaton, dermatomyositis or Trousseau's? Dermatomyositis can be seen in other conditions. Trousseau's can be seen in GI malignancies, pancreatic. Hypercalcemia is squamous cell carcinoma, whereas small cell carcinoma, Lambert-Eaton myasthenia is the most specific feature that you would get. 68-year-old, 5 years history of Parkinson's disease, worsening balance, soft voice, reduced facial expression. Family reports he's become forgetful, occasionally acts out of his rooms while asleep, sometimes shouting and flailing arms. Which of these is classical cause for his nighttime behavior? So sleep apnea, sleep terrors, nocturnal seizures, rapid eye movement behavior disorder. Remember, in Parkinson's patients, RBDs are very common and that happens during sleep. They become very agitated. Sleep apnea is seen in obese patients, night terrors in children, and nocturnal seizures are stereotypic nocturnal with post-ictal confusion. RBD disorders are very common in Parkinson's patients. 6-year-old rural community, high fever, cough, maculopapular rash, diagnosed with measles. To reduce the severity, what should be done? 2 doses of vitamin A, routine antibiotics, IV fluids, antitussive to cup the cough. What is proven benefit is to supplement vitamin A. So 2 doses of vitamin A 24 hours apart will decrease the complications, especially the eye damage and blindness. In almost 50% decreases the mortality also. Which of the following statements regarding acquired hypothyroidism in children is false? So remember, acquired hypothyroidism, most common cause is Hashimoto's. So Hashimoto's is the most common cause, so that is correct. So this is true. Primary hypothyroidism in children is associated with conditions like Downs and Turner syndrome. Yes, it is associated. Goiter in acquired hypothyroidism indicates hypothyroid status. Levothyroxine replacement 3 to 5 micrograms per day is the treatment of choice. Remember, goiter is not always a sign of hypothyroidism. It could be due to hyper, it could be due to euthyroid also. So goiter need not be a sign of hypothyroidism. So the answer here is C. The levothyroxine dose, you have to remember, it is 3 to 5 microgram per kg per day in children. In adults, we give around 1.3 to 2.1 microgram per kg. But in children, we give a higher dose so that the replacement is proper. That's what we use. The image depicting the Tanner stage, male sexual maturity. Based on the image, what is the Tanner stage? So here is what we see, the staging that has been given. The testicular volume is 10 ml and then sparse, there is the penile scrotal darkening is there. The pubic hair is darker and coarse and curler. So this belongs to Tanner's stage 3. So you should know about the Tanner's staging. Stage 1 is prepubertal, where the size of the testis is less than 3 ml and the skin, pubic hair, is same as the abdominal hair. The stage 2, where the size of the testis becomes around 4 to 10 ml, sparse growth of hair at the base of the penis you see there, and thinning and reddening of the scrotal skin has started. Stage 3, where the penile length is increased, the size of the testis is reached 10 ml, dark coarse, the coarseness of the pubic hair is seen. Stage 4, where you have an adult volume that you're seeing, and stage 5, where the testicular volume is 25 ml, and then you do find the classical adult genitalia. This is the SMR for boys. In females, we are using the breast as well as the gonadal regions. The prepubertal, no breast tissue, that's the stage 1. Stage 2 is where the breast bud appears, sparse hair around the labia, minimal pigmentation. Stage 3, where the breast is developed, the darker pubic hair has come. Stage 4 is where the adult type but limited hair to the pubic areas, whereas the adult breast contour with papillae alone would come. That is the stage 5 that you would see. During the forensic examination, the pubic symphysis of the male skeleton is oval, smooth surface with raised upper and lower ends. The outer and inner margins are well defined. What is the age that you'd see there? 20, 25 to 40, early 5th decade, or 60 plus. So the answer for this is C, that is the early 5th decade. What you'd remember is less than 20 years, the compact vein will be there. About 20 years, there is a marked irregularity. 25 to 40 years, the ridges disappear. And in the 5th decade, it becomes oval, smooth, raised margins. That is what they have given here. Oval, smooth surface with raised upper end margins. The outer and inner margins are well defined. So these are characteristic features that would be there. As the age crosses this, then the margins become less defined. During a burglary investigation, the police recovered a broken window pane with a tiny blood droplet and several glass shreds embarked in the suspect's clothing. According to Locard's exchange principle, which of the following best explains this finding? The suspect transferred the glass fragments from his clothing to the crime scene. That is wrong. Victim's blood were transferred to the suspect without reciprocal exchange. That is not material. There is a bidirectional transfer of trace evidence between the suspect and the crime scene. This is the classical Locard's principle. So Locard's principle, there is a mutual exchange where there is two objects, a person or object, come in contact, each leaves something behind. So here the blood droplets is from the burglar to the situation, and the shredded glass is from the location to the suspect's clothing. So this is a mutual transfer. That is the classical explanation of the Locard's exchange principle that you have. Students, in today's session, we discussed about some multiple choice questions, how to analyze them. These were from the INI-CET Grand Test that we had. We have understood how to narrow down the options. Also, we have discussed in and around the options certain other high yield points which can be asked in your main exams. Hope this session was clear. Thank you.